afternoon, everyone. I, Dr. Nivita Jevaria, presenting along with Dr. Hina Khan. We welcome the additional principal, Dr. Deepak Rai Singhani, sir, all heads of the department and colleagues to the 41st Dental Combined Round. Our presentation title is Impacted Teeth, Challenges and Contemporary Solutions. Let us begin with the first case. The patient is a 17-year-old female from Jaipur who visited the Department of Orthodontics and Dentofacial Orthopedics with a chief complaint of black discoloration of teeth in the front tooth region. In the history, the medical history, the drug history, dental history and habits shows no relevant history. The general physical examination, the height of the patient is 5 feet 1 inch, weight is 48 kgs, built mesomorph. In the frontal photographs, we can see that the vertical thirds and the grossly thirds are grossly equal. The profile of the patient is convex. Health remains average. The transverse arch relationship, the lower dental midline is shifted towards patient left by 1 mm with respect to the upper dental midline, and the transverse arch relationship, the overbite is 10%. The molar relationship is class 1 on both the sides and overjet is 2 mm. The upper arch is U-shaped, palatally placed and partially erupted 1-3, retained deciduous 5-3-6-3. The lower arch is square-shaped, crowding with respect to lower anteriors, retained deciduous 8-3, supernumerary tooth in the mandibular anterior region distal to 4-2. So how do we inspect for the impacted teeth? When a canine is not present by its eruption age, it can be inspected by the abnormal angulation of the lateral incisor and the presence of midline diastema. Now, for palpation, the index finger is used to palpate along the alveolar ridge. If the buccal bulge is present, it is impacted. If buccally we see that the bulge is present, the tooth is impacted on the buccal side, and if a palatal bulge is felt, the tooth is impacted on the palatal side. If no bulge is felt, the tooth may be deeply impacted or missing. So in our case, the buccal bulge is felt on the left side, so the missing tooth 3 is impacted on the buccal side, and the palatal bulge is felt on the palatal side, and its erupting teeth can also be seen, hence it is impacted on the palatal side. So what do you all think can be the reasons of impacted teeth in this case? Can anybody from the audience answer? Okay, so the main etiology is retained deciduous teeth. The patient was then sent for radiographic investigation wherein OPG shows an impacted 1-3, 2-3, 4-3 and unerupted 1-8, 2-8, 3-8 and 4-8. In the sector analysis, the 1-3 falls under sector 3 and the 2-3 falls under sector 1. So they are favorable to erupt. The CBCT of the patient shows that the palatally impacted 1-3 and labially impacted 2-3. Labially impacted 4-3. Now the question arises, why CBCT is done in case of an impacted teeth? Can anybody from the audience answer?
To check for the proximity with the adjacent.
Okay. And here?
PDN, viability.
Yeah, yes, you're correct. So it is done to basically rule out any presence of any etiology, to assess the viability of PDL and to evaluate the exact position of impacted teeth. It is also done to rule out resorption of adjacent teeth. Now, another question time. When is a tooth considered to be impacted? When do we see that a tooth is impacted? Can anybody answer? So normally, when about 3/4 of the root is developed, a tooth erupts. In the case of impacted teeth, more than 3/4 of the root is developed and it has still not erupted and it is stuck, then it is known as an impacted tooth. So according to Profit et al., the state of being completely or partially unerupted because of a physical barrier which prevents the tooth from assuming its functional position in the oral cavity. According to Greva et al., a tooth is impacted when it fails to adapt into the dental arch within the expected developmental time frame due to lack of space or obstruction by adjacent structures. Case summary: the patient complains of black discoloration of teeth in the upper front tooth region. The internal examination shows class 1 molar relation on both the sides and a retained deciduous in the first, second, and fourth quadrant. Impacted 1, 3, 2, 3, 4, 3, and the cephalometric analysis shows class 1 schedule pattern with orthodontic maxilla and mandible. The final diagnosis is Engel's class 1 Louis type 1 and type 2 malocclusion on schedule class 1 base with average growth pattern with retained deciduous 5, 3, 6, 3, 8, 3, impacted 1, 3, 2, 3, 4, 3, supernumerary tooth in the mandibular anterior region distal to 4, 2. Now the problem list is: firstly, the retained and decayed deciduous 5, 3, 6, 3, 8, 3, missing 2, 3, 4, 3, palatally placed or partially erupted 1, 3, and buccally impacted 2, 3, and 4, 3. Treatment objectives: the first is to extract the decayed and retained deciduous teeth. Second is to replace the missing permanent canines. Now, we have two options to replace the missing permanent canines. Firstly, the orthodontic treatment. The second one is prosthodontic treatment. Now let's see the advantages and disadvantages of both the treatment options. Prosthodontic treatment advantages: so it reduces the treatment time and has customized treatment. The disadvantage is it offers an artificial smile and causes harm to the sound tooth and additional surgeries like implants. The orthodontic treatment has advantages like it restores natural dentition, it preserves the periodontal support, and disadvantages are it has long treatment span and the patient discomfort and inconvenience. So why do we opted for orthodontic treatment and not prosthodontic rehabilitation? The first reason is the patient wanted to preserve her natural teeth. Now the question arises, why canine should be preserved? Can anyone answer? Can you please stand and answer?
Cornerstone of
Okay.
maintain a smile.
Yes. Yeah.
There is a concept called canine guided occlusion.
Yeah.
Basically, parents occlusions are one of the parts.
Yes, you are correct. Okay. So canines should be preserved as they are the cornerstones of the mouth and for dental arch integrity, canine guidance, and it provides a natural smile appearance and avoids unnecessary trimming of the sound tooth. So what are the benefits of choosing orthodontic traction of impacted teeth over prosthodontic rehabilitation? It restores natural dentition, it preserves periodontal support and has no artificial replacements. It has better functional outcomes, maintains bone health and is more aesthetic. Now moving forward to the treatment plan, firstly, we'll do the extraction of retained deciduous 5, 3, 6, 3 and 8, 3 and supernumerary tooth in the mandibular anterior region distal to 4, 2. Then leveling and alignment of the remaining erupted teeth. Then surgical exposure of 1, 3, 2, 3, 4, 3 and bringing the teeth in the line of arch with the help of an E-chain. So the surgical exposure of impacted teeth can be done by an open eruption technique and a closed eruption technique. So we opted for the closed eruption technique wherein a wide surgical flap including the attached gingiva is reflected. The thin overlying bone is peeled off and attachment is wanted. The flap is resutured back. So why do we use closed eruption technique instead of open eruption technique? The first main reason is as it erupts through the attached gingiva which stimulates the normal eruption. What are the other advantages? It causes less discomfort and rapid healing, good post-operative hemostasis, and causes immediate traction and high degree of reliability of bonding. So in the case of the lower impacted 4-3, Firstly, we did the extraction of the retained deciduous and supernumerary distal to 4-2. The impacted 4-3 was allowed to passively erupt in the oral cavity. So in this case, why do we opted for open eruption? Firstly, the impacted mandibular canine was near the line of occlusion, and the impacted mandibular canine had sufficient amount of attached gingiva beneath it. So now we'll see the progress. After 6 months of the surgical exposure, we can appreciate that the tip of the canine is emerging in the oral cavity. After 9 months of the surgical exposure, we can appreciate the canine is emerging along with the attached gingiva. And after 3 months of surgical exposure of the impacted 4-3, we can see that it is passively erupting in the oral cavity. Intraoral photographs before treatment, after 15 months. So here we can see the transition of our treatment, starting from surgical exposure and seeing the canines erupting in the line of occlusion, and this is the current status of the patient. Here we can see that the canines are erupted in the line of occlusion. Moving forward with the case 2, the patient is 15-year-old female from Badikui who visited the Department of Orthodontics and Dentofacial Orthopedics with a chief complaint of upper left missing teeth in the upper left front tooth region. The medical history, drug history, dental history and habit shows no relevant history. The general physical examination, the height is 5 feet, weight 45 kgs, build is mesomorph. In the frontal photographs, the vertical thirds and horizontal thirds are grossly equal. The profile of the patient is convex. The FMA is low. Transverse arch relationship, the upper dental midline is shifted towards patient right by 2 mm with respect to the facial midline, and the lower dental midline is coincident with the facial midline. Overbite is 70%. The intraoral examination, the molar relationship is class 2 on right side, and on the left side it's class 1. The overjet is 1 mm. The upper arch is U-shaped and missing 2-1, 2-2 and 2-3 can be appreciated. The lower arch is U-shaped and symmetrical. Radiographic investigation, OPG. Here we can see that the odontome is present in the anterior maxilla, impacted 2-1, 2-2. In the sector analysis, the angle with the midline is 26 degrees, so it is favorable to erupt. The angle between the long axis of the canine and with the midline, this angle is 26 degrees, so it is favorable to erupt in the oral cavity. Cebicity of the patient shows labially impacted 2-1, 2-3 and palatally impacted 2-2. It shows the presence of an odontome. So what do you think could be the cause of impaction in this case? Can anybody answer? It is odontome. Case summary. Patient complains of missing teeth in the upper front tooth region. Intraoral examination shows molar relation class 2 on right side and class 1 on left side. The number of teeth present, 1 to 7 teeth are present in the first, third and fourth quadrant and missing 2-1, 2-2 and 2-3. Cephalometric analysis, the class 2 skeletal pattern with prognatic maxilla and retrognatic mandible. Final diagnosis, angles class 2 subdip on right side, on skeletal class 2 base with horizontal growth pattern and impacted 2-1, 2-2, 2-3. The problem list is impacted 2-1, 2-2, 2-3 and the treatment objective is to disimpact the impacted teeth. Moving on to the treatment plan, firstly the surgical exposure and removal of the odontome. The surgical exposure of 2-1, 2-3 and attaching a lingual button with an E-chain, then alignment and leveling and bringing the tooth in the arch with the help of an E-chain after leveling the arch. So this is the surgical exposure of the odontome. So here we can see that the impacted 2-1 odontome, and impacted tooth 3. So after 9 months of the surgical exposure, the leveling and alignment of the erupted teeth, we applied forces with the help of an E-chain to bring the impacted teeth into the arch. So after 9 months, after alignment and leveling of the remaining erupted teeth, we applied forces for the traction of the impacted teeth. Now here the question arises, why alignment and leveling of the erupted teeth before applying forces is necessary? Can anybody answer? So because a heavy passive arch wire provides anchorage, a solid base. So it prevents the unnecessary deactivation forces on the remaining teeth. After 18 months, we can appreciate that the central incisor has come into the line of arch. After 19 months, the crown of the canine can be seen erupting in the oral cavity. This is the current status of the patient. In this photograph, you can see that the palatally impacted canine is erupted into the line of occlusion, and a space preparation is done to bring the palatally impacted tooth 1, tooth 2 into the arch. This is the pre-treatment OPG. The post-treatment OPG, we can appreciate that the eruption of tooth 1, tooth 2, and tooth 3 into the line of occlusion. Now I would like to call my co-PG Dr. Hina Khan to carry forward with the discussion part. Thank you.
Good afternoon, everyone. Now I will provide an overview of impacted teeth, emphasizing on the etiology, classification, prevalence, and strategies. Moving on to the etiology, it can be broadly classified into local, general, and trauma. The local etiology includes tooth size arch length discrepancy, prolonged retention of early loss of deciduous teeth, abnormal position of tooth bud, alveolar cleft, ankylosis, and cystal odontome. Now the general factors include primary failure of eruption, cleidocranial dysplasia, Down syndrome. These systemic conditions are associated with multiple impacted teeth. Now comes the trauma. In form of physical injury to the primary teeth, which can cause arrest of the root development of the permanent teeth, which result into short or dilacerated root, which are seen over in the pictures. Now comes to the prevalence. The maxillary third and mandibular third molars are more prevalent. Then comes the maxillary canines, second premolars, maxillary central incisors, mandibular canines, lateral incisors, and the last is the first premolar. Now the third molars are most frequently impacted teeth due to space constraints and late eruption. So the treatment choice for them is extraction. Whereas the canine, although is the second in prevalence of impaction, but is the most important tooth for the orthodontist, as it plays a crucial role in function and aesthetics, therefore requires a crucial management. So why canine should be preserved? As Dr. Nivita said, cornerstone of the mouth for dental arch integrity, canine guidance, provide a natural smile appearance, and avoid unnecessary trimming of the sound tooth. Now we'll see the incidence of the impacted canine. The incidence of impacted canine is 1 to 3%, whereas the palatal impaction on the palatal side is seen more. Unilateral impactions are seen more than the bilateral. Impaction on left side is seen more than the right. Female has more tendencies for impaction than male, and impaction in maxilla is seen more than the mandible. The ratio is 20:1. Now we are going to see the classification. Impacted canine can broadly be classified into labial and palatal. Several other classifications exist to categorize impacted tooth position, severity, and prognosis. Like Erickson and Crowell classification, it is also known as sector classification. According to the location of the impacted canine from distal to mesial towards the midline, the sectors are numbered 1 to 5, where the sector 1 being the most distal and sector 5 being the most mesial. As we can see in this picture, When the canine is in the sector 4 or 5, it has only 64% chance for eruption. It is mesial to the lateral incisor. And when it is present distal to the lateral incisor, it has 91% chance of eruption. Mahatma et al. Classification. This classification is for the mandibular canines. This is classified into 5 types. The type 1 is when it is present, when it is crossing the midline, it has only 45.6% of chance of eruption. Whereas type 2, which is lying horizontally below the apices of the mandibular incisors and has a chance of eruption of 20%. Whereas type 3, which lies on the contralateral side besides the canine, either mesial or distal, and has a 14% chance of eruption. Whereas the type 4, which lies horizontally below the apices of the canine on the contralateral side and has 17% of eruption. Whereas the type 5, which lies vertically between the midline, has the least chance of eruption, that is 1.5%. Now the treatment difficulty index by Sarapit et al. The main factors include 10 points to judge how hard it will be to bring an impacted tooth in the dental arch. These are rotation, angulation to the midline. If the angulation is more than 30 degrees, the prognosis reduces. Age of the patient, coincidence of the arch midlines, alignment and spacing of the upper labial segment, vertical height, buccopalatal position, condition of the primary teeth, missing teeth, and horizontal position. Now determining the prognosis. Prognosis is determined by the position of the teeth, either it is favorable or unfavorable, age of the patient, availability of the space, and presence of the adequate width of attached gingiva. Treatment planning. Now coming to the treatment planning, 3 options are considered. First is the resolution, second is the extraction if it is required in overall treatment plan, third is the substitution of the canine with an adjacent tooth or with prosthesis. Now protocol for disinfection. The protocol, the removal of the etiology is done. As we done in our second case, the etiology was removed first. The management of the space ensuring the natural eruption, surgical exposure, and traction into the line of occlusion. So removal of the etiology, which can be resistant overlying soft tissue, supernumerary teeth, and odontome. In our second case, the etiology was odontome. Addressing these obstacles can create the right condition for the tooth to erupt normally. Now the steps of the resolution are alignment and leveling, space preparation, and anchorage. The surgical exposure of the tooth is done to maintain the patency of the exposure, to permit the attachment bonding, and to re-expose the tooth if it is buried under the healing tissues. So these steps ensure control and successful eruption of the impacted tooth through surgical and orthodontic collaboration. Now the techniques of the surgical techniques are open eruption technique and closed eruption technique. The open eruption technique is window technique and apically positioned flap. In window technique, a circular excision of the overlying mucosa and the thin bony covering is done. Whereas in the apical repositioned flap, the flap is repositioned apically. This was described first by the Van Arsdale and Kohn, and post-operative gingival recession and orthodontic relapse are commonly associated with the apical repositioned flap. The closed eruption technique, in this, a full thickness flap is raised and attachment is bonded. Then the flap is sutured back to its former position. As we can see in this case, an auxiliary spring, keloid spring, is being used to track down the impacted teeth. Now the Cresani tunnel technique, it is a modification of closed eruption technique. A tunnel is made through the recently extracted deciduous teeth to mimic a natural eruption. Now the treatment components. The treatment components are the attachments, intermediaries, and auxiliary springs. The attachments influence the eruption of an impacted tooth, and attachment must be bonded to. These attachments have changed over years. So this is the lasso wire which is unsettling the impacted canine. Then came the orthodontic bands. For these, wide surgical exposure was required. Then the threaded pin came, but now in use are the bonded attachment. All these techniques which I described below are now obsolete. Intermediaries are used for the traction of impacted teeth and securing the impacted tooth to the arch wire to facilitate eruption and alignment. So these are the ligature wires, elastic threads and slingshots. Auxiliary springs like baluster spring, monkey hook and Kilroy spring are used to deliver the light continuous force to move the impacted canine. These allow three-dimensional control of the tooth movement like rotation, tipping and alignment. Therapeutic extraction is a part of an overall treatment plan. So up till now we were talking about the resolution of the impacted teeth. Now if the treatment plan of a malocclusion requires extraction like by mixed cases or class 2 cases, class 2 driven cases, the impacted teeth can be considered for the extraction. Now if the canine is extracted, then comes the part substitution. So the canine substitution is opted when there is surgical inaccessibility, extreme displacement, unacceptable shape and size, presence of a pathological condition. So the canine can be substituted either by the adjacent tooth like premolar or by a prosthetic substitution, that is implant. Canine substitution with the premolar has advantages and disadvantages. The advantages are the time will be reduced, the invasive surgical procedure will be eliminated, and the disadvantage is enameloplasty which can require an RCT. Aesthetics will be compromised. Now let's dive into the evidence-based orthodontics. So, in this article, this is a systemic review which shows when there is higher alpha angle, higher vertical position and more nasal sector of the impacted canine are related to the less successful interceptive and active treatment solution, long treatment time and inferior outcomes. This article shows that early treatment of palatally erupted maxillary canine by extraction of the primary canine. This is the etiological factor for an impaction tooth. So if we remove it early, then it will be the passive eruption of the impacted teeth is appreciated. So the periodontal status of impacted maxillary incisors uncovered by the two different surgical techniques. In this, the open and closed eruption technique was used, and the central incisor uncovered by the open technique has longer clinical crown and decreased bone support compared with those treated with the closed technique. And they said that bulk changes with the crown discoloration only seen in the trauma-related group independent of the surgical technique. Now uncovering the labially impacted teeth, apically positioned flap and closed eruption technique. So the vertical relapse, as I said before, the vertical relapse of the uncovered teeth with apically positioned group, they concluded that labially impacted maxillary anterior teeth uncovered with the apically positioned flap technique have more anesthetic sequelae than those uncovered by the closed eruption technique. So the periodontal outcome of a surgically exposed and orthodontically aligned buccally impacted maxillary canine. It's a systemic review. So has slightly greater probing depth, potential bone loss and increased clinical crown length, but they are not clinically significant. So the take-home message: prevention and interceptive measures reduce the treatment complexity. Closed eruption technique generally provide better periodontal aesthetic outcomes compared to the open. Surgical exposure with bonded attachment enables controlled orthodontic traction while preserving the gingival health. Interdisciplinary coordination between the surgeon and the orthodontist is crucial for the long-term treatment success. Thank you. Now the house is open for the questions.